just want to say welcome to the podcast with CAPSA, and our guest today is Rob Boyd, the Executive Director of the Oasis organization in Ottawa, well known here in Ottawa and nationally for his compassionate approach to helping people where they're at, his creative thought processes around that, and leading change in Canada around services to people who are suffering. And Rob, I just want to say hi. Oh yeah, and Rob's also the award winner of the Recovery Day Ottawa, Perseverance and Commitment to Recovery. And so that's a pretty full plate, Rob.
Yes, yeah, and thanks. I'm really excited to be having this conversation with you today. It's been quite a journey, and I really appreciated that award a few years ago and recognizing really what it takes is actually the name of the award that I really like, that compassion and perseverance, because that's exactly what you need in order to affect change around issues that have a lot of stigma and have a lot of kind of innate opposition to them. And so substance use and harm reduction are definitely areas that are rife with that.
Absolutely, in this concept that it is going to take some perseverance. It is going to take some continual and constant effort, and some, I think the word that came to mind earlier when we were chatting was some humility of when we're creating change, that we're probably not going to be perfect at it. And,
Yeah, absolutely. I mean, we're gonna, we make a lot of mistakes along the way, and if we don't come at the work that we do with humility, then we're just going to keep making those same mistakes over and over again. And so we just need to recognize it. We need to have people around us who are comfortable calling us on it, so that way we can make those adjustments and re-strategize, because fortunately there's still quite a bit of leeway in terms of how much mistakes you can make. I mean, there aren't that many that are so catastrophic, but it's really really important in this. We're talking timelines of decades to really get to the change that we want to get to. So we really kind of focus in the moment, but you really always have to have your eyes fixed on the horizon as well, and what that end goal is.
Yeah, I think that's a wonderful approach. Many of us, of course, would like to have the wand where we can do that, and we're, the confidence that if we do what I say, then everybody's going to be okay, but none of the evidence because we haven't done it yet. And so what if we're wrong, and what if we just need to adjust? And that's going to be so much easier if my thing is that if we know for sure, the one thing that we know for sure is that change is needed. And the second thing we know for sure is that that's going to be a process, and self-reflection, self-examination, and outside feedback.
Yeah, and the other thing is not to get into an echo chamber as well, right? And that's something that you and Recovery, CAPSA are really kind of good at, is making sure that you are engaging stakeholders who are not typical allies as well. And it's so important to do that. And when we were doing our advocacy for supervised consumption, we were particularly looking at, just to kind of broadly stereotype, like the conservative mindset.
Yes.
And what messages are going to resonate with them. Because it's very different from when you're talking to somebody with who's an ally who already is on board versus the person who is not sure about this, really sees life fundamentally differently, has a whole different framework for social policy and how they see the world. And so you really do need to adapt to that, and you need to invite them into the conversation, because otherwise, you are in this echo chamber, and you're not adjusting your message, and you're also not listening or hearing what people's concerns are.
Well, and the idea that if we need to have change, we need to have that come from the people that don't think so.
Yeah,
and so that's an education piece. That is an invitation piece.
Yeah. I mean, our target in our communication strategy wasn't kind of the people who were never going to get on board with us, but we knew that there was a large group of people in the middle who, our belief is, if you give them information in a way that's respectful and you give them time to think about it, that they would come around to it. You know, I used to say, I hold these truths to be self-evident, you know, like it was pretty obvious to me that this is what had to be, what had to happen. Yeah. But I didn't see any benefit on calling out people who didn't agree with me at this time. There was a real concerted effort here by the media in Ottawa, because at the time, Mayor Jim Watson was not supportive of supervised consumption services. Yeah. And they were really trying hard to get me to call out the mayor on this, and I absolutely refused to, because I didn't think that that was going to help our cause at all, and that we really needed to be, again, just a calm, cool, rational voice, explaining to people what's going on. The moment I get into a fight with somebody who's in the opposition, I lose.
You know, that's just it. I think the heart of what we're looking for here today, Rob, is that the fact you've been very successful at creating change here in Ottawa. And I know that, you know, I can see the response already. Rob wants to tell us how many other people were involved, and it wasn't all about him. But you were the face of the newspaper, certainly, Rob, and you were the person who was holding this line that said there's pain taking place, but if I bring the anger on top of the pain, no change will take place. And so that's a decision that has to be practiced, I would think, pretty consistently. Were there moments when you just wanted to raise your voice?
Yes, yes, of course there were, but yeah, but it wasn't going to serve the community well if I did that, right? And so I really needed to come into this with a recognition that, I mean, I came into this with a lot of privilege, and I still have a lot of privilege, right? So, you know, some of it's earned for sure, but, you know, I came with a lot of, and to spend, you know, it was 25 years at that point of my career working with people who were homeless, street involved, mental health addictions, and to watch them struggling every day, but every day kind of waking up with still hope that things might become different for them. And, you know, who was I to give up on that, or who was I to undermine that work? And that my role and what I needed to do was to try to shift the conversation in Ottawa, not just for the people who would be using supervised consumption services in Ottawa. Like, we had the bigger plan in place as well. Like, we needed to liberate all people who use drugs from the horrible stereotypes that were kind of keeping them down. So we always had, even then, you know, we were working on supervised consumption. We worked for 10 years on it, so it was a very long time. Yes. You know, the media stuff was really over about a 2-year period that we were doing that, but we always had in mind that this was a conversation that we wanted to speak to the entire community about, and that we wanted to let them know that what they knew about substance use and people who use drugs was actually wrong, and that all of the stereotypes, in fact, people generally are like, the people who use drugs are generally the exact opposite of the stereotype of what people have out there. So we were fighting, you know, 50 years of drug war propaganda. But to deliver that message, it had to come across in a way that people could consume.
And there's the rub, eh? There's the compassionate piece, where the people that are having harmful attitudes in supporting harmful social behaviors are the very ones we need to be peaceful with, so they can hear.
Yeah. Well, you know, I mean, it's really, I mean, everything that we did was based on the principles of motivational interviewing. So this is something we'd all been trained in. It's how we work with our clients, where, you know, you don't directly, you know, basically the principles are give information, express empathy, develop discrepancy, and roll with resistance, right? So this is what we do with our clients every day, and in terms of trying to create an environment where change is possible. And that's really what this is all about. And so we just took that and we applied it to the community level. And we said these same principles of change are the ones that are going to help people to understand and to hopefully start changing public policy. And educating the electorate, or the electorate or the general public, was a way to get political support for the types of things that we needed, because politicians are not going to lead on this. They're going to follow. It's just very high risk, or hopefully it's less high risk now than it was 10 years ago. So we had to, so we took these principles that we knew worked. This is basic change theory about how people change, and we applied it more globally, and it worked really well.
turns out people are people.
Yes.
You know, what blocks change is what blocks change.
Yeah.
You know, and what people don't understand they're afraid of, and what they're afraid of they don't want to be close to or think about. And so, and if they're wrong, you know, we have a school system that very early educates us around doing things right and being right and getting marks for being right. So the idea that, you know, adults working and voting and having jobs are wrong about some fairly significant issue in our society is naturally repellent to them to consider. When you bring in the fact that they have family members and friends and colleagues involved with the issue, and then you say, well, you've been harmful to them with your attitudes and your beliefs.
Yeah.
Well, that's really into scary territory now. And so it's best to approach with this idea that, you know, hi, I may have something that may be of value to you if you can hear me, but I've always been really bad at hearing people yelling at me. I'm not sure what you're
Absolutely.
but, you know.
Yeah, you entrench, you just stop and you dig your heels in. You know, the moment somebody tells you that you have to do this or you have to do that, you're at loggerheads then.
So, I guess, is it fair to take a moment, Rob, and just recognize, because of the pain involved, because of personal losses involved, that we want to make sure that we're respecting the fact that some people need to yell out in their pain. And the difference between that is then they're not advocating, they're expressing their pain. And then if we're going to move into change, then we need to take that pain and bring it into purpose and skill set. Is that reasonable?
I think that, yes, it is reasonable, because, I mean, where is that coming from, right? When somebody is so angry or so upset about, you know, what it is that we're proposing to do, whether it's supervised consumption site or whether it's, you know, setting up a treatment center in their neighborhood or something like that. One thing that I've observed is that people don't feel well taken care of in our society, and they feel like they're not being taken care of. And it's pretty, I mean, I can reach out with, I do have empathy for that. I do get why people don't like to live in neighborhoods where people are injecting drugs in the open. Like, I totally understand why people don't like that. We have to reach out with empathy to the people that are opposed to the work that we do with the same that we do with the people who use our services. And we need to understand and recognize what it is that they are losing, or what it is that might be motivating that. And, you know, they're not our clients, they're not the people that we work with in the same sense. So we're not going to necessarily get into that level, but we just need to acknowledge that these are realities. And you know, I chose this field, I chose this place of work, and things like that. Other people didn't choose to kind of be in this neighborhood, and you know, we've seen quite a bit shifting in Ottawa, particularly since the pandemic started. We have a lot more visible homelessness than ever before. We have a lot more public intoxication than ever before, and to just say, you know, well, that's tough is not, it's not right. I mean, first of all, we want people to be in better spaces. They don't have to be publicly intoxicated. But at the same time, we have to recognize that it is a problem for the neighborhood, and that's something that collectively we should be trying to address.
You know, I work on a stigma campaign, Rob, and I also have to tell people, you know, I did a lot of damage in my relationships. That's not everybody who has the situation I have, but that was my experience, right? And that I wasn't a good taxpayer. I wasn't someone who, you know, you knew for sure I was going to stop at the stop sign, and, you know, so those are very real. But who I was and how I wanted to be was much different from how I was able to be. And so we're asking that sort of piece where can you know, there's behaviors that aren't okay, but people are okay. And so we're, you know, not judging the people always necessarily by the behavior, but also recognizing, yeah, no, that would disturb you. Someone sleeping on your porch when you come out in the morning, it might give you a scare.
Yeah, for sure. And, you know, and that can contribute to the stigma that the community experiences. You know, a lot of what we do is around enabling people to take responsibility for themselves. So we have this idea of the someone who uses drugs is irresponsible and reckless, and they don't really kind of care about their health and things like that. And while that can be true, a lot of what we do is we're teaching people that you are actually in control of this. They don't feel like they are, you know. I mean, people are told that they're powerless over their substance use. People are, or lives are directed by, you know, shelter staff, by probation officers, you know, and things like that. Like they are very tightly controlled, so they've kind of given up a lot of that internal locus of control. Yeah. And so a lot of what we're doing is kind of putting it back on them. We have a housing first program for people who use drugs, and I remember at one point early on, one of the people in this program coming to complain to me about how we put her in this apartment way out of the downtown area, and I said, no, we didn't. You chose that apartment, remember? And you can choose again. You can leave that apartment and you can go somewhere else. But it's a concept that a lot of us, it can be difficult to kind of appreciate how it's kind of this institutionalized thinking for, and I'm talking about, you know, certainly the most marginalized of folks that we're talking about who've spent a lot of time in various institutions like hospitals and jails and shelters.
Sure. Well, and I'm going to suggest to ask your thoughts on, you know, criminalization of people that use substances has created its own sort of invisible institutionalization around some behaviors and around the inability to talk and so on. What do you think about that as sort of another level of institutionalization that takes place without the walls, without the direct contact sometimes?
Yeah, that's interesting. I hadn't really thought about it that in that way. For sure. I mean, and when we're talking about stigma, I mean, one of the main purposes of criminalization is to produce stigma. You know, it's stigma as a deterrent, so that other people don't have to take that on. So we're not going to address stigma unless we deal for substance use, unless we address the issue of criminalization. So to me, that's such a key piece to it. But that whole, you know, talk about identity, you know, being, you know, having a criminalized identity is very kind of self-limiting as well. And it's actually self-limiting, but it's also societal limiting, of course, because it's really difficult to reach your optimal recovery if you have a criminal record, because so many doors get closed because of that. You know, you can't get the good jobs. Sometimes a lot of places, landlords are requiring criminal records checks. So, you know, drug crimes are often life sentences for people because it really does impact them, for the rest of their lives.
Yeah, absolutely. And you know, then there's so I look at criminalization, and then I look at persecution that's based on the criminalization, and so I see all our first responders and our health professionals who are pre-criminalized, so to speak, because if a nurse is struggling with substance use, loss of job, you know, it's one of the first things. Police officer, loss of gun, loss of badge, even if it's on some sort of leave thing, but loss of status, all that takes place without ever being charged with possession, you know, and so those precursors to criminalization, the persecution of people, because criminalization is up here, but back here is all this persecution.
Yeah, I mean, we have, we know that everybody has some risk for substance use disorder, particularly jobs that are really stressful, like policing, nursing, paramedics, like, you know, jobs that have a lot of responsibility.
Yeah.
You know, it's a tricky issue because, you know, these jobs have a lot of power, and we need to make sure there are certain things that we'd want to make sure that people are not intoxicated while they're doing. Airplane pilot would be a really good example for me, who doesn't really like to fly, but police with a gun. Yeah. You know, I mean, you want to make sure, or a nurse who has, you know, medication errors and things like that. But yeah, we have to get to a point though where that can be dealt with without the stigma that comes with it. And you know, you're a police officer, and your job is your sworn duty to uphold the law, and now you are actually breaking the law. So you've got several layers of crimination and self-recrimination that are involved in that. That's such it's an even bigger hurdle to overcome.
Well, there's an irony sometimes when we look at our complex society, and sometimes we see people in the greatest need physically, socially, and mental health-wise and substance use-wise are bumping into inadequate services, the wrong services, a lack of services, but they're at the door. And then we have a whole portion of our society who has not those immediate detriments to health in terms of housing, but aren't able to get to the door because of all that stuff in between them. And so I guess there's a lot of work to do.
Yeah, and very different strategies. I mean, that's, you're describing what I would call the hard to reach population. Typically, the people I work with are called hard to reach, but they're actually quite easy to reach if you're respectful and provide them with some really practical things that they need right now. It's the person who doesn't see themselves in this story of substance use disorder or overdose risk. Those are the people that I fear the most for. Because they're really hard to access and they don't have the tools and the behaviors to protect themselves.
Absolutely, or the voice.
Yeah.
One of those things. So, so you've talked about 10 years to go from we need to do this to actually doing this, and then the adjustments afterwards and going, well, yes, okay, we need to do this, but a little differently than I thought, and a little, Now we're getting closer to this conversation on decriminalization. We're getting closer to this conversation on regulated supply. We're getting to begin to think that some of these things may well happen, that at one point were future stories, and not much more clear here. What do you see in terms of challenges moving towards that in a way that is helpful to the most people?
Oh, okay. Well, you're into the harder questions. I think we're always we have to always think about this as two, probably more than two, but for simplicity, two different populations. So we've got to look at those who are, quite severely impacted by things, and then you need to look at those who are, along the continuum, aren't kind of as far as long. They don't have as many barriers to recovery. They don't have as, they're not as marginalized and things like that. Because I think sometimes we were looking for one answer for all of those people, and I think it's different. So for example, I'll give you a concrete example, is around the delisting of OxyContin and the kind of the prohibitionist impulse that the government had to, stamp out a particular drug, and therefore the problem would be solved.
Yes.
But what we had was, at that time, was that the College of Physicians and Surgeons of Ontario sent out a notice to doctors just kind of cautioning them about high dose, patients on high morphine equivalent doses. And so a lot of doctors took that as a reason to take people off their medications and very rapidly. So we'd heard the stories about people who were just abruptly cut off, or they were rapidly titrated down, which led them to the illicit market. And this was just at the time that we were just getting our first powdered fentanyl in the market. So it wasn't the crazy drug market that we've got out there right now, but we had fentanyl that was pressed into pills, and
very acceptable form for people that normally wouldn't consider other forms of
this was the market that people were being pushed into, and so we saw an escalation of overdose after that happened. If we had said, and really I think this was the intention, but if it had played out that you got to treat the people who are already in this mess differently from the people coming on, right? So it makes perfect sense that you don't prescribe as much pain medication, you don't prescribe it as long, but you got to treat the people who are completely dependent on these more high morphine equivalent doses very differently. So I think we got to, when we think about legalization, regulation. To me, decriminalization is across the board. I don't see who benefits from the criminalization of drug use. Really, like it's a social policy that was developed in the 1950s and 1960s, and you can go back. Canada's first failed drug policy was the Opium Act, over 100 years ago. But the war on drugs type of thing is based on the 60s, right? And so we don't currently have any other social policies that were developed in the 60s as part of our society now. So we're hanging on to this one. So I don't know. I can't see the downside of criminalization, other than I'm not sure that it's going to have the impact that we want it to have on the opiate crisis. That's the only reality, I don't see how that's going to drive down the overdose deaths. I think it's going to do a lot for reducing stigma. I think that's the main reason that I would advocate for that. Legalization, I think that the trick is to think about it in terms of intelligent regulation, and what it looks like for someone like me who doesn't have an addiction, doesn't have substance use disorder, might look different than what it does for somebody who comes into our shop and to get services with us. So for me, if I had access to some recreational MDMA or even cocaine and things like that, it would probably be really different, because I have other things in my life, right? And I don't have this relationship with drugs that, unfortunately a lot of people do. What that looks like, though, for somebody who is right now accessing a toxic supply of drugs in the market might be something like safer supply, where you actually provide them with actually a pharmaceutical grade drug for them to have, not in the interest of kind of treating them, but in the public health interest of preventing an overdose death.
Well, and Rob, thank you for all that, and it is a difficult question, and I think you've outlined some of the things that I hear from other people, is that this is complex. This one will work for everybody. Steve West was on our show a couple weeks ago, and he was talking about, if he broke his leg, they don't x-ray someone else's leg to see how to fix Steve's. And so, we have individuals with relationships towards substances whose lives are in danger. And we need to have some system that says they're not all the same. And a group of people that don't have that relationship yet, that I would say that prevention is probably a good idea. And when I say that, I don't mean the prevention from using substances or the shaming of substance use, but I mean not being in a position where your life is endangered because of your relationship with substances. The overdose crisis has changed from the initial period of fentanyl, an unknown, unrecognized condition, in my mind, Rob, where people were taking it accidentally, people were discovered in the substance accidentally, and that conversion that takes place around substance use, where it becomes something that's being sought after, something that is now needed in the very real sense of nothing else works now for me. And it's still in an unregulated, uncertain dosage. But we don't have a lot of uninformed people who are taking substances who don't know the risk involved. So hence supervised consumption sites are active, are busy, are reversing overdoses, are saving lives constantly, because people with those substances know of the risk, but they also have that need to use. Does that make sense?
Yep, yeah. Yeah. I mean, I can't understate how much fentanyl has changed the game for us. Like, it is fundamentally a new world out there for us, and talking about humility, it's really difficult to figure out what to do next. The services and systems that we have in place are really intended for a heroin market or for an OxyContin market. They're not intended for the drug supply that's out there right now. And so we're really scrambling, trying to figure out anything that might work with this. So we're, for example, when it comes to injection drug use, if somebody, say, is using hydromorphone or OxyContin, these drugs stay in the system for a lot longer than fentanyl does. So we were talking about 3 or 4 injections a day. So our model of supervised consumption was based on this idea that people didn't have to inject more than 3 or 4 times a day. Whereas with fentanyl, the range that we're researched here in Ottawa is 9 to 13 injections a day. So this whole system capacity has been thrown off by this, and we can't possibly do that. And plus, the risk of overdose has escalated exponentially at the same time. So people want to be using this site a lot more, but we've created this horrible bottleneck for people, based on how rapidly this drug supply has changed. The other issue is treatment. So the main way that we've been treating opiate use disorder in Canada has been through methadone, and now buprenorphine and naloxone is the other treatment that we have. We have Sublocade now, which is, it's a slow release under the skin injection. But so methadone was the main one. So we have really good access to methadone here in Ottawa right now. Very low barrier. If you want, today you could go and get started on your methadone. But the problem is that you're not going to feel that initial dose, and it's going to take a while for you to get up to a dose that you're actually going to begin to feel the effects of. That's going to moderate your use of the illicit drugs, and then hopefully up to a therapeutic dose. We can't get people to there because the use pattern that they have, their identity as a drug user is now consumes them 24/7. That with every hour they need to redose basically because they're dope sick constantly, and so there's no time for anything else. There's no time to connect with a case manager about housing or to come into the health center so we can start the ODSP application and things like that. So their entire cycle is consumed by this. And so the ways that we were going about things up till now are not working anymore either. And we don't know how to get to that next level. So this is why we have things like Safer Supply. Like that we're trying to try new things right now. And from our conversation before, make new mistakes. Like we have to make new mistakes because the old mistakes are we should have learned from them by now.
Well, and again, the need to take that managed risk of change because existing, the losses are tremendous. And so they're at that, we believe this will work. There's some sort of stuff about this, but we know that if we do nothing, the problem continues to exacerbate and get worse. And so the risk of, because I know some of the population will say, well, hang on, you're not sure that you're going to be right? But we're right about the need for change. We're right the need that if we don't take steps forward, we'll never get to a solution. Is that fair to say, Rob?
Yeah, we have to try things. But we also have to be, again, very humble that, safe supply is not going to be the answer. I'm supportive of Safer Supply. I'm critical of Safer Supply. I'm a fan. I'm advocating for IOT, so injectable opioid agonist treatment, but that's not going to be the answer either. Like that's the problem, is that we've got all these great ideas, and there's no one thing that's going to do this. And part of me is a little bit afraid that there's nothing that's going to do this. It's really hard for us to compete with fentanyl and what it is that people are getting from this out there. And, in the past, we were able to wait it out. We were able to, be supportive of people, provide them with some services, and we knew that there was a risk that something was going to happen to them. But now it's so, as you say, we've had, double the overdose deaths in Ottawa, 2020 over 2019. There's this sense of doom of we can't move fast enough. And so when we move fast enough, we start making mistakes, or we're not kind of being self-critical about things because we just want it to work. Yes. We just really want it to work. But we do have to take that time. And that's also when we make mistakes in terms of our advocacy and our change theory, is because we feel this urgency for change. We don't want to wait 10 years for things to be different. We want them to be different today, and that's very frustrating. But we have to, those of us who can anyway, have to be able to, hold back on that and to, again, just keep the eyes on the horizon.
Sure, and I just want to highlight that I'm speaking with Rob Boyd, who spent 10 years in a tireless effort to bring supervised consumption into Ottawa here to save and secure lives. I'm not talking to somebody who's not uninformed. I'm not talking to somebody who's not been an advocate for change. And I think that's really important in this conversation, Rob, that we are not naysayers here, but we are very much interested in the outcomes in people's lives and the security of their lives, but we're also very aware that, we don't know. We're not sure.
Yeah.
In that place, that is a place of humility.
Yeah, and all along in our advocacy efforts around harm reduction in general, I mean, these are not our goals. These are not our end goals. I mean, drug policy reform is our end goal.
Yes.
And things like supervised consumption or needle exchange back in the day, these are just markers of success along the way. We have fought for every inch that we have gained in harm reduction and in the promotion of the health and wellness of people who use drugs. None of it has come easy to us. So, but they are definitely worth the fight. And I think this is such an important issue for this generation to tackle and to overcome, that we have to get people involved in this, and we have to get people involved in the right way and support them and empower them.
Okay. I have another difficult conversation.
Okay.
Is that okay?
Yes.
Yeah, it's, I've asked Rob to be here and have this conversation, and we're unscripted, and we're going to go down some places, and this idea that we don't have to be right, and that we're going to take a look at the editing at the end together and make sure we doesn't mispronounce any words or anything like that. So we have a group of people who are right there in harm's way, that we're actively seeking for the quickest life security we can get. And then we have a group of people who might be vulnerable to get there. How do you see protecting those from not moving forward to there? Do you have an idea on that at all, Rob?
Well, I mean, this is kind of those bigger issues of things like the social determinants of health, of having people have a place in society. I think that's what drives a lot of our mental health and our substance use and substance use disorder, is the social dislocation that people experience, that there's no place for them. We're not a culture that is nurturing, talking about this, people who are opposed and so angry, it's really clear that these are hurting people and that they're not feeling like their needs are being taken care of by society. And so why should somebody else get what they're not getting, kind of a thing. Yeah. So but these are such big kind of fixes, but we really, fundamentally what we need to give for people on both sides of that is hope and purpose. Those are the things that get people through the day and build resilience and help them to see a future other than the one that's in front of them right now. So, those people who are, who are beginning to struggle, we need to invest a lot more in some good evidence-based treatment, and we need to destigmatize substance use disorder, just so that people feel okay to go get help, and that when they access the system for help, they're not stigmatized. That happens just far too much still. The stigma, reducing the stigma helps people to see themselves in the story, helps them to say, hey, I'm one of these people, I have this thing that they're talking about. And then makes it easier for them to access. But we really have to invest a lot more into some good evidence-based care. We were talking just this week about, we have a rise of crystal methamphetamine use here in Ottawa, the last couple of years. And there's no pharmacological agent that is going to, we don't have a methadone equivalent for stimulant use. Mm-hmm. But there are some evidence-based treatments, but they're really for this population that you're talking about. They're not as effective as people who have significant barriers to recovery. So some good contingency management with cognitive behavioral therapy is the thing that's going to help prevent that condition from escalating or devolving into people who would then come to use my service. But nobody's doing it. Yeah. And there's no investment in this type of intervention that I've seen. We're always hopeful. We've got now a new mental health and addiction center of excellence in Ontario. So, we're hopeful that things will come up, but we really haven't thrown the money into this that needs to happen. It has been underfunded for decades. And, and we've just allowed this problem to fester and fester and fester and have done nothing about it. And now the price tag is big, yes. But we have to spend the money if we want to turn this around.
Well, and I'm going to touch on the Mental Health and Addictions Center of Excellence and look at that word, end addictions. And we know 80% of Canadians use substances. Not many of them ever develop an addiction or a substance use disorder. and yet they all have health concerns and need education and to know what are healthy choices around their substance use. And so we can see sometimes that in a very systemic way, unless you're really, 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 really sick, you can't talk about your substance use. And which of course makes those people that are suffering the most even harder to have that conversation. So we've introduced this idea of substance use health so that we can look at Canadians around substance use, not a small population. But we believe that that will expand. I just wonder what your thoughts are on that kind of a concept.
Yeah, no, I think we need a new framework for sure. I think that you know, the ways that we have looked at this traditionally, you know, the disease model or the 4 pillars and things like that. I mean, they were useful during their times to move the conversations then, but we need to move the conversation again, and to get people to see this from a completely different framework. So. I think the more that everybody can see themselves in this picture, because it's true, we are all. I would have thought it was higher than 80% of Canadians use substances, but I guess you know, I mean, if you're talking about everything, then you know, it is near universal.
Yes.
And all of these substances have benefits and have harms, and you know, some of them have more harms, but that's mostly because of drug policies than it is the drugs themselves. But yeah, we have to think about the health impact of my drinking coffee as much as I drink coffee. We have to think about, I was thinking the other day, because I had stopped by at my local liquor store to grab a bottle of scotch, and I thought, man, that's getting expensive. And then my next thought was, that's a good thing.
There's a reason we have some of that stuff in place, you know. And the other thing I was thinking, you know, to get your thoughts on, Rob, and it just came and went, is this idea of health, that we can attach substance use with the word health. Many Canadians are going to take substances to improve their health all their life. Canadians are going to use substances around ceremony. And then we have these sort of predatory practices where people design substances to create addiction amongst the vulnerable, to create that hourly need instead of the 6 month or the 6 hour, I'm well now. And so there's the decriminalization, and there's also what do we do with adversarial. I don't want to use stigmatizing language, but people that are adversarial, predatorial to the population. And I look at obesity in North America, and you go back and when did we first start having people design soft drinks that made you thirsty?
Yeah.
Well, just to give the general population an idea that this is real stuff, people design soft drinks to make you thirsty, so you can imagine that people design drugs to make you hungry for more.
Yeah, and that's basic free market capitalism, right? I mean, there's no better example of the free market than the drug trade, where it isn't completely unregulated. And it is completely, and so you think about the risk and the profit. So the risk is going to jail for it, and the profits are absolutely immense. And pretty much all of that profit is based on criminalization or prohibition. That's what has created that profit margin. So, and then when, you know, in the age of fentanyl, when you don't have to have complex importing of the substance anymore. And you only need small amounts of the substance. You don't need large amounts, so your likelihood of being detected is nil. You know, it's very low. I mean, there are fentanyl busts that happen and things like that, but it's so low, and the profits are so high that it's a no-brainer. And you know, I really do think that, you know, as we were doing some drug checking in the supply, and we kind of watched how the fentanyl cocktails or the opiate cocktails were kind of emerging in the drug supply, I really think it was intentional. I think that it was people were trying to figure out what's the best combination of these fentanyls, analogs, and, you know, U-class drugs to optimize their profits by keeping people just well enough that they needed their next dose. And so I don't think it's by accident that it's come out this way.
Absolutely.
And that is that market. So, but I mean, what do you do? I mean, there are always going to be people who are going to be there to exploit human pleasure and or, you know, reduction of pain, depending on what the motivation is in terms of the substance use.
Yeah.
So I think that the best we can think about is making sure that we provide people with some alternative to that, recognizing, again, if our goal cannot be the complete elimination of the unregulated market, because anytime your goal is to complete anything, you're going to fail. So what you really need to do is you need to provide alternate sources of that dopamine rush.
Yes.
Or those oxytocin coming into the system. So that may be drugs. I mean, there's lots of other things that will release these chemicals in our brains if we don't have anhedonia and we haven't lost that ability to feel the pleasure that other people feel all the time. So it's really about finding stuff to compete with what's out there, and it's much harder now with the folks that come to see us to compete with that market that's out there. But I think that you still can with people who are, recreationally using substances. Make sure that people are involved in other things: sports, arts, music, faith communities, just other things that create that sense of belonging, that give them that those warm fuzzies and give them that thrill of discovery, or whatever it is that kind of turns people on and naturally engages these systems within our brains that make us feel good.
Yeah, absolutely. I'm one of those people who lost a lot of that. I grew up across the street from a dairy, and so ice cream, my brain still loves ice cream, but my system does nothing when I eat it. There's no pleasure. So every week I go and get a little piece of ice cream to see if it's come back, but it hasn't, and it may never come back in my life. And so these are very real things, and not everybody understands that the system gets impacted, the brain neurology, the brain chemistry gets impacted. And so the idea that how come you don't enjoy the sunny day? Well, because it doesn't give me any pleasure, What about the breeze on your face? Well, I didn't notice. My body doesn't respond to that anymore. And so people are going to have a struggle to find a way towards what is going to be a meaningful life, what is going to work. And some of them, some of those breaks may not be repairable, and then it's a question of, well, as a society, are we going to punish people?
Yeah. Especially if those breaks happen very early in life, right? So that we know from the adverse childhood events research, it's really clear that a lot of this stuff happening to people when they're very young, under the age of 6, we can't repair that once it's done. So that detachment and that disconnection that people have, or that inability to relax all of those things, we can't restore it after that, because they were never formed properly in the first place. So there's certain realities that we have to live with this, and again, to take these now adults and to punish them for that, it just doesn't make a lot of sense. We care about them when they're kids, but we don't care about them when they're 22 years old and really struggling.
I remember someone once said I was the poster boy for an Ontario welfare program around people who had my issues, and I was 56 at the time.
They call it backhanded compliment.
Well, I knew they meant well, right? And in many ways, they were talking to the person who got wounded a very, very long time ago. And, it was a true story. I needed society's support. I had done my very best, and it wasn't there. And so when I look at people, I always ask people, can you see the child still? And do you think for a moment, if you're wondering what they're thinking, do you think the child was planning to get here? I don't know. And so I wonder what happened. That this is the very best that's been able to become so far, but not from lack of effort. I don't know any child who doesn't want to have a good life.
Yeah. And at the very least for us, that child needs to be seen, and it needs to be told that it's okay, and that we are accepting them, and that is so profound. You know, people need to, it has to be acknowledged, you know, that we see you. It's okay, we're okay with who you are.
You don't have to sit pretty for us, and you don't have to roll over, you don't have to do any tricks to have our respect and our presence with you.
Yeah, yeah, you are valued as you are right now.
Isn't that what we all want?
Yes.
Hey?
Yes.
Well, can we start by giving it instead of trying to get it?
We all have our insecurities, we all have the things that we're not, you know, and we're taught this. Of course, this is all, you know, this is all done within the context of the culture that we grow up in, with these messages that we're inadequate all the time, which is also driving this. We're not as good, we're competitive with our neighbors and things like that. So we're all told that we don't meet this mark. Obviously, you know, when we're talking about people who've got abuse in their past, it's much more serious, but there's this this collective sense of inadequacy and not being seen and not being accepted for who we are that we really need to shift.
So we get to the equity piece, and you know, when people talk sometimes about prevention and education, you know, adverse childhood experiences, it turns out it seems like the greatest prevention we could do would be to have an equitable society.
Yes.
Which probably isn't going to be perfect, but we now know the real costs of an inequitable society are the problematic situations we have now with people who didn't have opportunities, whose opportunities were taken from them, who, you know, started behind the start line.
Yeah, we've lost a whole level of work and employment for people.
Yes.
You know, if you don't go to university today, a college or university, there's really not an awful lot out there for you, and not everybody is you know, has those intellectual skills or the money to do that. But the problem is that, you know, a lot of the places where people could go into the manual labor has been offshored. It's just not available here anymore. So we've had this whole social dislocation of people who really have no purpose and no hope, and they are not don't have the opportunity to meaningfully contribute to society. That it just creates despair. And, you know, we get so much of our identity from what we do. And when you don't have an identity, we don't have a positive kind of social identity, you'll take on any identity you can take, because not having an identity is intolerable psychologically. So taking on an identity as a drug user or a person who uses drugs is better than no identity.
Absolutely.
And it actually gives you hope and purpose. The hope and purpose is that I'm going to score more drugs today, and I got to go out and do this, and then hopefully, you know, within that, there's also this hope that someday things will be different for me, which, you know, is my experience of most of the people that come to use our service, even, you know, when they're the most captured in what's going on with them, is that they still have hope that tomorrow could be different.
Yeah, and if we don't hold that with them, and occasionally for them, you know, hope, you know, this beautiful thing about hope is that it can become a weight, and it can become a head bender, you know, because sometimes people don't have the evidence yet that their hope is going to make a difference. And so if people with hope have not experienced that hope is of value, then when we engage with them, hope, we're going to need to be really gentle, in my mind, to make sure that it's also, yeah, geez, I'm, you know, hoping tomorrow is going to be a great day. But that's not a piece of judgment, and it was not a good day. I'm still hopeful for the next day.
Yeah. No. Somewhat related, I'm reminded of a study that I saw at a presentation about where the researchers asked people who, what types of things kind of give you pleasure in life, you know, and so, you know, and then they asked people who use drugs the same question. And so, you know, people are, you know, would be doing things like, well, I like, you know, playing sports, I like reading a book, I like, and so the interesting thing was that both groups had the same list of things that they like to do. Then they asked the second question is, when was the last time you were able to do that? And the group of general population, far more, it was a recent experience that they had. And the people who use drugs, it was something that happened years ago was the last time they were able to do that. So I think that's quite telling in terms of just first of all, how common, we are all the same, but it's really about that inequity and that unequal access and that lack of opportunity for even the basic things that we know give us pleasure.
I was staying at the hospital, and they had a hospital volleyball game for the people staying at the hospital, and I went up there and I jumped up to block a shot, and when I jumped up I was 28, and when I landed I was 56. 28 years had gone by since I played volleyball, which I loved playing volleyball, and so yes, I would have had the same list, and I absolutely understand that everybody would. What do we want, right? Pretty simple. What do I like to do? Pretty simple. And those are often the experiences. And for some of us, it'll be read a book and be quiet and have nobody around. But there's these things that we have, eh? And then, yes, equity. Can I do those anymore? Do I have access to those anymore? And I'm hopeful for the future. And a lot of that, Rob, is built around the changes that you have been standing in front of and speaking for, even as you gather allies around you. And I'm really comfortable to have this conversation with you today. I'm very curious to see what happens next. And I'm very hopeful that we are not looking at one solution to fix all methods, and that conversation can take place, and that we can be directionally correct and make adjustments as we go. Does that sound okay with you?
Yeah. It's a lot. There's a lot of work ahead, and it's not up to us. It's up to us more collectively, and this is going to take decades. And I don't know about you, but I'm not going to be doing this for decades. So I think that we need to kind of lay the groundwork and then build up the next level of leadership. I think that certainly the work that you have done. I mean, in terms of making sure that voice of lived and living experience is at the table. That's the leadership that we need as well. So and we got to work on these alliances, right? I mean, it's not about whose voice is more important. It's about what collectively we can do.
That's a beautiful way to express it. So I'm not even going to touch that. That's just beautiful. And yes, I'll have a little blanket on my knees in a number of years from now, and I'll be interested in what's going on, but I won't be much part of it anymore. And change is going to come through others, and so I have a lot of respect around that idea. I said I wasn't going to say anything, now I'm going on, Rob. Anyways, I love talking with you, but I think our time must be just about up. So Rob Boyd, thank you for everything you're doing and everything that you have done, and I look forward to working with you as we go forward.
Yeah, me as well. Thanks for having me.
Okay, thanks.